Welcome everyone. It's a pleasure to call this meeting to order and welcome. My name's Fiona. It's my privilege to be President and CEO of Providence Health Care, and it's Providence Health Care's privilege to host the BC-CfE. First of all, wanted to start off by acknowledging that we're here on the land that was always called Aylsham, but is now known as the West End of Vancouver. It is the home of the Musqueam, Squamish and Tsleil-Waututh peoples. We recognise that Indigenous people of this land have always been disproportionately impacted by infectious diseases, by epidemics and pandemics, right from the smallpox epidemics of the 1860s. And part of our work, as part of our principles of social justice, is to ensure that we particularly address all those individuals who are disproportionately affected. So today, as probably everyone knows, because you're in this room, is World AIDS Day. This is a United Nations recognised day since 1988. It's been marked across the world. And in my little bit of research for this morning, I realised and I was surprised by how few United Nations days there are for specific diseases. There's one for HIV/AIDS, there's one for malaria, but not many. And I think that is symptomatic and symbolic of the impact that HIV/AIDS has and continues to have across the world. So I was thinking, what do I think the purpose of today is? And in my mind, there were three things that I kind of wanted to do. The first of all is to remember, and to remember everyone that we have lost. I personally live in the West End, and I see that loss every day. And we have lost tens of millions of people across the world from HIV/AIDS. And it's, I think, really important for us to remember those individuals, their families, their friends. Secondly, to celebrate progress that 30, 40 years ago, imagining that we would now have things that we'd be focusing on in terms of how do people age with HIV. The impact of those drugs, the impact of what we can now do. Like, science is really amazing, and we should absolutely celebrate all the work that has happened. And thirdly, what I wanted to do today was to recommit to actions that need to be done going forward. We are aware, and the wording I think is about at a crossroads. There is so much that needs to be done, and we mustn't lose all the progress that has been made in the last few decades. Those were my thoughts, but I also have thoughts from someone much more important than me. Premier David Ebie sent a message and asked for this to be read out. So I'm going to try and channel David. I'm always kind of conscious that I'm kind of quite tall, but David's one of the few people that makes me feel small. So this is a message from our Premier. As Premier of British Columbia, I would like to offer a warm welcome to everyone attending today's World AIDS Day event, jointly hosted by the BC Centre for Excellence in HIV/AIDS, Providence Health Care, Health Information for Men, HIM, and the Pacific AIDS Network, PAN. World AIDS Day, established in 1988 as one of the first global health days, provides an important platform to raise awareness and unite people in the ongoing fight against the HIV/AIDS epidemic, as well as reflect on the many lives that have been lost over the years. British Columbia is proud to have been a global leader in the fight since the 1980s and opened Canada's largest treatment, education and research facility, the internationally recognised BC Centre for Excellence in HIV/AIDS, in 1992. Though huge advancements have been made, there is still much work to do. As new cases of HIV rise in BC and across Canada, it is through the important work of organisations like the BC Centre for Excellence, Providence Health Care, HIM and PAN that we continue our path towards the elimination of this epidemic. I would like to thank the organisers, as well as recognise everyone who works to further research, development treatments, provide education and raise awareness of HIV/AIDS. Together we can break down the stigma, support people living with this diagnosis and stop the spread of HIV. Signed, Honourable David Ebie, KC. Moving from one important person to the next. My next job is to introduce Dr. Julio Montaner. People may have seen that the initial program was for me to introduce Dr. Heidi Fry, and very unfortunately she was planning to be here until about 2 hours ago, in which she unfortunately woke up with a really bad migraine. And as a fellow migraine sufferer, I'm completely sympathetic to this, so sorry that she can't be here. So I'm moving on to introduce Dr. Montaner, and I always get the easy jobs. I mean, how do you introduce Dr. Montaner? But I will have a go. So I think everyone knows that Julio is obviously director of the BC Centre for Excellence, is Killen Professor of Medicine at UBC, and his impact on HIV/AIDS worldwide through both his leadership on triple therapy and heart, and also treatment as prevention, and the United Nations model of 1990-90, moving to 95-95-95, is immeasurable. Julio came to St Paul's and Canada in 1981. I understand he'd originally planned to stay only 1 year, and it is our immense good fortune that he changed his mind. I hope that was a lot about what we could do here in this organisation. I think it might also be about one woman who subsequently became his wife, but we are really grateful to her. So thanks so much, Julio. We're really happy that you're here, and it's a pleasure to introduce you. Thank you.
Thank you, Fiona. Thank you very much, and thank you everybody for being here today. I recently visited Ottawa. I was hosted by Dr. Heidi Fry. It was a very productive visit. I had an opportunity to speak to her colleagues in the Senate and some of the parliamentarians, trying to push the agenda that I'm going to describe for you here in further detail. So without further ado, let me just go to my slides. This is going to be a brief summary of where we are at the moment regarding HIV/AIDS, both here and globally. As you know, since the inception of the center, we have been offering treatment and prevention to people living with HIV or at risk for HIV, and this has been quite successful. We have a cumulative experience of 193,000 persons years when it comes to the antiretroviral therapy portfolio, and equally a large experience with HIV PrEP, with 46,000 patient years of follow-up. And with that information, we're able to describe for you what the impact of highly active antiretroviral therapy, which started in 1996, then expansion to treatment as prevention starting in 2006, the 2008 treatment as prevention pilot, moving on to 2010, the treatment as prevention expansion to the whole of the province, and ultimately adding PrEP in 2018. And to make a long story short, the epidemic started somewhere around here. This is AIDS mortality, climbing very quickly, and you see it declining with a mere availability of highly active antiretroviral therapy. It declined by 2/3. But we were very concerned that we were not able to go any better than that, as you can see here, until treatment as prevention became the norm. We were able to basically bring AIDS mortality to a lowest level historically, with a 97% decrease since 1994, at the peak of the epidemic. HIV incidence is shown in this curve, and you see it declining steadily in the province of British Columbia, so that by 2023, we had a 90% decrease in HIV new infections, something that we celebrated with Adrian Dix when he was the Minister of Health. And we basically were in a position to announce the end of the epidemic phase of HIV/AIDS in British Columbia. As you see here, PrEP play a critical role in bringing down the number of cases clustered phylogenetically within the province of British Columbia. This is work that Jeff Joy has done for us. And this clearly demonstrates the synergy between treatment and prevention, in this case PrEP. We also have shown a similar synergy between treatment as prevention and harm reduction in the context of injection drug use. Both of these strategies are essential to controlling the epidemic. As a result of this, British Columbia has gone from having the worst epidemic in the 90s to having one of the best controlled epidemics among the large provinces in Canada. Unfortunately, our example has not been heeded by the rest of the country. And as a result, we face ourselves today in a situation that is quite concerning. You've seen the number of people living with HIV, living longer and healthier lives as a result of treatment and prevention. The epidemic was under control, but unfortunately, the number of people that are entering treatment in the province of British Columbia has increased in the recent years, and this has been at the expense of what you see the green here, people who had been previously treated with antiretroviral therapy, which gave us the tip that something was going on that we needed to investigate further. And when we did so, this is Junine Toe's analysis of the socio-demographic profile of individuals entering the programs between 2017 and 2024. You see that among individuals who are antiretroviral therapy naive, there is a proportion of people who are coming into the province with pre-existing HIV. On the other hand, among those that are antiretroviral therapy pre-treated, the proportion of patients that come into the province from elsewhere being previously treated is also significant. And importantly, the number of people coming from outside the province, naive or pre-exposed to antiretroviral therapy, has continued to grow. And unfortunately, this is the trend that we're seeing increasing over time, which is actually quite concerning. Thank you. Fortunately, because we have a policy of making treatment available to people the moment that they enter the province and they are being diagnosed, or the moment that they enter and they identify as being elevated risk for HIV in the case of PrEP, offering people the treatment while they are waiting for normalizing their situation with regards to MSP coverage has allowed us to control the spread of HIV regardless of the increase of number of new patients that we're seeing in the province. This is illustrated here. This is a further analysis of Dr. Joy's analysis, the phylogenetic analysis. And what you see here is the number of cases in the province coming down. New cases start to rise in the last couple of years. However, if you look at the number of cases that are clustering within the province, clustering phylogenetically, indicating that these are infections that have been generated in the province, the number continues to decline, while the number of cases that are not clustering within the province, they cluster outside the province, on the blue, is increasing, showing or confirming, phylogenetically speaking, that the transmission in BC continues to go down, despite the fact that we have an increased number of individuals, both living with HIV and at risk in the province. Much of this can be explained by the failure of the rest of the country to control the epidemic. As you know, a number of years ago, we used the BC data to generate the UN targets, the 90-90-90 and the 95-95-95 that Fiona referred to. This is the strategy that we put together to try to achieve a 90% reduction in morbidity, mortality, and transmission by 2030, which is predicated on the notion that by 2020, we needed to have at least 90% of the people living with HIV diagnosed, at least 90% of those diagnosed on treatment, and at least 90% of those on treatment biologically suppressed, with the same parameters increasing to 95-95-95 by 2025. 2025 is today. We are at the end of 2025. We don't have yet the formal analysis regarding the progress towards the 95-95-95, but I give you what data we have in that regard. This is for the 2020 target, the 90-90-90. This is your benchmark, 90-90-90. British Columbia has surpassed the 90-90-90 targets in the three domains. No other province has had that degree of success, and that's part of the problem, as I will show you in the next slide. You see here the impact of highly active antiretroviral therapy on HIV incidence in British Columbia, as we described already. You see basically the lack of impact of highly active antiretroviral therapy on HIV incidence in the rest of the country, simply because they have not rolled out antiretroviral therapy and PrEP to the extent that it should be rolled out to be able to demonstrate a public health benefit. The reason for the failure to achieve this it can be better understood if we redraw the 90-90-90, referring not to the previous target, but actually to the 100% of people living with HIV, so that the 90-90-90 becomes 90, 81, and 73, respectively. If you want to remember easier, 90, 80, 70, that's the trick. When you do that, you now have the benchmark shown here. Again, British Columbia surpassing the benchmark on all three domains, but no other province is basically doing so, as you can see here. And so what this is basically saying is that this is not a matter of having one out of the three 90s on target. We need to have all three above target to be able to show a public health benefit. At the end of the day, if you have 100% of the people virologically suppressed, but you only have a fraction of those diagnosed on treatment, as is the case of Alberta, you're actually not going to meet the objective. And that's where the issue gets confused when people refer to the progress towards the 90-90-90 as if it was sufficient to arrive to one of the three targets, which is actually totally inappropriate. And that explains why Saskatchewan and Manitoba are seeing a bad situation at the present time. And although I have not been able to illustrate these in the slide because the data is not publicly available, confidential reports from the rest of the country shows that every single province in the country, the large provinces I'm talking about, is showing an increase in HIV cases as we speak. While I was in Ottawa, I received a private communication that PHAC is about to announce the progress to the 95-95-95, and it has been reported to me that the current numbers are 89, 85, 95 by the end of 2022. Public Health Agency of Canada will spin this as a partial success. I think it's a partial failure, and it's a disgrace. If we redraw the target based on the 100% of people living with HIV, the 95-95-95 becomes 95-90-85. Canada's progress towards the 95-95-95, which in this case would be 95-90-85, is shown here. 89 as opposed to 95, 76 as opposed to 90, and 72 as opposed to 85. That's the reason why this is not working. We have not been doing the job the way that it's supposed to be done. And I need your help to inform our policymakers that this situation is unacceptable, given that treatment and prevention are both cost-saving, not just save lives, save new infections, but actually save money. And we have shown this repeatedly again and again and again, not only in Canada, but actually in the south of the world. This is a cost-averting intervention. Now, moving on to the global situation, things were coming along reasonably well. In fact, as you can see here, the number of people globally on antiretroviral therapy has been increasing. As a result of that, we have seen a remarkable decrease in the mortality related to AIDS. Certainly, we're not at the target for 2025, but we're approaching the target, and therefore, this is worth continuing. HIV and AIDS-related death globally have decreased by approximately 50%. Infections have decreased by approximately 40%, as you see here, not quite on the target, but actually the trend is quite encouraging. The area where there is a lot of residual concern is PrEP. I think that the biases against the use of PrEP are demonstrated in this slide, which shows that the target for coverage with PrEP should be somewhere around here. We are tenfold below where we should be. And this is a problem because PrEP is synergistic with treatment when it comes to preventing HIV transmission. And so this situation is unacceptable. And the only explanation for PrEP not being rolled out is because there is prejudice regarding the rollout of this intervention, much like there was prejudice against the rollout of birth control pill when we were in our youth. And this is unacceptable. Today, nobody would deny a woman access to birth control treatments, and yet we're not advancing PrEP at the global level purely because of these type of concerns. I am ashamed that President Milei in Argentina announced this week, that he's withdrawing all funding for PrEP in Argentina, despite the fact that I was there about a month ago advocating for the expansion of PrEP with the support of the medical community. This is a shame, and it's happening all over the world, including across the country in Canada. And if that was not bad enough, then we have Trump, which is really a disaster. John Cohen from Science called his interventions regarding the cutting of the funding for HIV/AIDS globally a bloodbath. And I think that's quite an apt description of what we're facing. Notice that all global health has now decreased in funding by 80% in the United States, HIV/AIDS by 71%, but don't fool yourself, because this is the decrease in HIV funding, but this has been also associated with decreasing funding for tuberculosis, malaria, family planning, nutrition, mother and child health, in the range of the 80% cuts. This is devastating. The effect of this on the global community will be felt for years. We have actually undermined a program that was one of the most successful programs globally. Let me just be clear. UNAIDS is going to be phased out starting January 1st, 2026, 4 years ahead of the 2020 deadline to complete the strategy. Am I mad? I'm beyond mad. This is actually totally intolerable. HIV infections globally are expected to increase back to the level that they were at in the early 90s, before all of this started. We are going backwards at a speed that is unprecedented. AIDS-related deaths globally are expected to go back to the peak that we were experiencing in the 2000s. This is unthinkable. I cannot believe that I had to approach Fiona and say, we may have to reopen the AIDS ward. This is pathetic. When Carney said, when he was campaigning, that if the United States no longer want to lead, Canada will. We actually wrote to Carney. We asked for meetings, basically death silence. And not only that, but this week, for the first time in 20 years, Canada has substantially decreased the funding for the Global Fund.
If the United States no longer wants to lead, Canada will.
Well, show it to me. When we started talking about treatment prevention, the economists had this cover questioning whether or not this could indeed be the end of AIDS. And the answer is very clear. Yes, it could be. Unfortunately, the way we're going, it won't be. And what we need is to get really politically active to ensure that this message is heard at the provincial and at the federal level. This is a tragedy. We have shown then that treatment and prevention can promote targeted disease elimination and contribute to healthcare sustainability. What else can we offer to suggest that this should be a priority at a time in which our healthcare system is in such a dire situation? And to show you how this actually can be leveraged to a greater benefit at the public health level, let me remind you that we have been in the midst of an epidemic of sexually transmitted diseases in this province and this country and this world for decades. Chlamydia has increased by 33%, gonorrhea by 182%, and syphilis by almost 400% between 2012 and 2022. We are seeing, for the first time in ages, neonatal syphilis in the province of British Columbia. And all of this is totally preventable. We have actually implemented, with the support of the government, doxycycline for prevention of syphilis, gonorrhea, and chlamydia. And we have early data that Junine prepared for us, showing the before and after rates of syphilis among people engaged in the doxy prophylaxis program. As you can see here, the effect has been remarkable. More than 70% reduction in syphilis among those taking doxycycline for syphilis prophylaxis. So much so that for the first time, and to our surprise, we're seeing that the provincial number of diagnoses for syphilis is starting to decline. This is with a small number of people that we have been treated. If we are actually able to roll out this program to a larger number of people in the province, we would see even a greater benefit. Chlamydia, Similarly, high levels of chlamydia before engaging in the program, very low levels thereafter, 77% reduction in chlamydia before and after the engagement in the program. Less so for gonorrhea, only 15% reduction, but as you see here, this is showing an impact at the provincial level in the case of chlamydia, not so much in the case of gonorrhea. There is new data. The French have actually published a study using a gonorrhea vaccine that it remains experimental, but there is a suggestion that it could add to the mixture, and we're looking forward to more data before we can move that initiative forward. The other condition in the STBBI domain that is of concern is hepatitis C. Fortunately, with the direct-acting antivirals, we are able to basically bring the likelihood of transmission in people living with hepatitis C to very low levels. Of course, in addition to that, these agents, within a matter of weeks, can cure hepatitis C, which is a very desirable outcome. And we are working with BC-CfE to try to expand that program, something that we hope we can achieve within a matter of the next 5 years. The burden of these diseases across Canada is quite substantial. As you can see here, this is the last data that I was able to find. HIV, there is an estimated 65,000 people living with HIV as of 2022 in Canada, 214,000 for hepatitis C, 12,000 for syphilis, 104,000 for people diagnosed with chlamydia, and 32,000 for people with gonorrhea. All of this is a burden of disease that will be virtually eliminated if we do the right thing, and these strategies are extremely cost-saving, particularly doxycycline, which is actually a generic medication that is very, very easy to take and very inexpensive as well. So with that in mind, we have put forward a proposal to expand the scope of our work to certainly continue the HIV part, expand the PrEP as we discussed, expand the doxy for prevention of bacterial sexually transmitted infections, and also expand the treatment and prevention of hepatitis C, as I discussed. The plan is simple. If we bring these strategies together, there is a significant overlap between individuals that need and can benefit from these interventions to be co-administered. If we were able to effectively roll this out, we could see dramatic improvements in the health of our community, and at the same time, we would be strengthening our healthcare system. I'll leave you with that message of hope. As you can tell, I'm not happy about the current situation, and I urge you to get active to support our request for PrEP and HAART to be included in pharmacare at the national level, for strengthening of the monitoring and evaluation of the programs across the country, and for strengthening the support of the community, which at the end of the day are essential to implement these programs effectively and in a sustainable fashion. Thank you very much.
Thanks so much, Julio, for that very powerful and impactful presentation. I'm now delighted to invite up two more distinguished guests who I'm very privileged that we've got joining us today. First of all, Evin Purdie, an experienced community leader who spent his career supporting people on the margins. Evin is the Exec Director at HIM, Health Initiative for Men, and a registered clinical counsellor. And Evin Jones from the Pacific AIDS Network, PAN. Evin brings over 30 years of experience as a leader and advocate within the community-based response to HIV/AIDS and related social justice issues. Since 2008, she's been the Executive Director of PAN, a provincial network that supports over 40 member organisations across BC and the Yukon, all of whom are responding to the HIV epidemic, viral hepatitis, working on the front lines, promoting access to harm reduction and challenging stigma and inequities. PAN centres the voices of people living with HIV and other people with lived experience to guide programmes and services and to ground research and policy change. Thank you very much for being here. So I think that you both will have some introductory remarks, and we'd love to hear those. And then we will move to some questions. I have a couple of questions to kick things off, because I know there's always a kind of reluctance, but please do take this opportunity, and I know that they, and also Dr. Montaner, would be happy to answer any question in the room. But over to the two of you for some introductory remarks first. Thank you.
Good morning, everyone. Thank you so much for being here. My name is Evin, and I'm as I was already introduced so kindly, I'm the Executive Director at HIM Health Initiative for Men. But what I actually am is I'm the son of a public health nurse who used to tell this story about this patient she had at Toronto Hospital who would repeatedly come back. He was sick. He would kept getting these kind of strange diseases. No one could quite figure out what was happening. The nurses there were also observing that there were all sorts of men coming in with all sorts of tropical diseases, all sorts of confusing infections that shouldn't be happening, getting sicker and sicker. She would tell the story about this one guy who would come in and he was very artistic, is what she said. And he would do small paintings for all the nurses. And after I came out of the closet, she put that little painting up because she kept it for 40 years. My mom's a conservative Christian woman, but there was something about this disease, there was something about this paradigm that she knew was important, and she kept it around. So for me, my opening remarks really are just to kind of, because I think the questions will get into it enough, but my opening remarks are really just for us to all remember the people that are impacted by this. Julio just did an amazing job presenting data that talks about people's lives, people's well-being, people's history. That's actually what we're talking about here. We've been fighting this battle, whether you're a medical care provider, whether you're a gay man, whether you're a queer woman who goes in to visit people in the hospital for the gay men who are barred from being able to do so. That's why Evin and I still do this work, is to keep on that battle. So at HIM, what we're doing is, you might think we're just for gay men. We're not. We're for gay, bi, queer men, and gender diverse people. We are queer folks leading healthcare work for queer folks. And what we rely on is institutions like the BC-CfE to ensure that medications can be accessed universally, to ensure that data predicts an accurate story about what's happening, because then we can actually do our work in community well. HIM has been translating the research that has been happening at the BC-CfE since the beginning of our existence. We've been making it legible for our communities. We've been making that information digestible. We've been involving the community in the paradigm. In BC, we have a very interconnected community, a set of people who know about the BC Centre for Excellence, who know about the legacy BC has had with HIV. So we actually do have an active community in BC, and we may be able to be the seed that plants the garden, but it can't just be Julio yelling. It has to be all of us. Julio's great at yelling. We need the right people yelling, and he's the right people for sure. But that's my introduction of me. We're going to talk about, I'm sure, kind of like how HIM sees ourselves being involved in the paradigm moving forward. That's my little personal introduction, which I think is grounding, because we do want you all to ask questions at all levels. Evin and I are here to contextualize that kind of community linkage about who are the people who are actually, well, I would say benefiting from the work that happens here. BC-CfE and the community organizations are twin moons. We can't really exist without each other. So, Evin, then you're okay with following my impassioned speech?
Thanks, Aaron. That was really lovely. Hi, everyone. My name is Evin Jones. I'm the Executive Director of PAN. And first of all, I'd like to thank Dr. Montaner for the invitation and the BC-CF team. It's great to be here. It's great to be invited. It's great to have community in the room. And I think it's just more important than ever for all of us to be united and to be reinforcing each other's work and doubling down on those messages. That, Julio laid out the situation. Things are very challenging globally and nationally. We need to protect what we have here in BC, and in order to do that, I agree with Erin, we need to work together. I do want to just acknowledge again that this is the first day as well of Indigenous AIDS Awareness Week here in Canada. And I think that it's just, I appreciated that Fiona mentioned or talked a bit about the disproportionate impact of HIV on Indigenous people and communities. And I think it's really important for us to remember too our legacy of racism and colonial violence and all the ways Indigenous people and communities have been impacted by that in our healthcare system, corrections, the child welfare system, and so on. And so, today, World AIDS Day, it's such an important day to think about our calls to action. And in that too, I think another call to action is just really thinking about resourcing and supporting the leadership of Indigenous people and of Indigenous organizations and people in their advocacy and in their ownership of culturally safe, trauma-informed services and programs. So really appreciate the chance to be mindful of that today myself. And I'm really looking forward to this panel and more conversation. I feel so privileged to be the executive director of PAN, and we support 40 community-based organizations all across BC. And these are folks too who are present today in the room, and their spirit of their work. And some of the organizations I'm privileged to work with are really big and have a lot of staff. Some are just like one or two people working away and toiling away in little tiny communities, and often with very little resources. And I'm just always so impressed by how much community-based organizations are able to do, often with very little resources. Sometimes they have a lot of resources, but often they have very little. So that's something I just want to be mindful of as well. And then the other thing is, it's just such a delight actually to be in the room and see some people I haven't seen in years. And so much about what PAN does is work with people living with HIV. And it's those people, like folks here in the room today, I see you out there, and it's like your leadership and your wisdom that is so critical as well, because it's through your experiences that we get to figure out the solutions that work, and the power of you adding your voices to the calls to action that we've heard today from Julio is just, it's so powerful. So that's something else I'm really delighted to acknowledge.
Thanks so much, and I hope people are getting their questions planned out in their head. Just a couple of intros from me. First of all, a general one. I think it would be really helpful to everyone in the room if you could provide your perspective on the state of HIV in BC and how your two organisations are currently involved in the response.
So as many of you in the room may know, the ways that HIM has been involved in HIV is largely in prevention. So HIM was an organization that almost kind of budded off from AIDS Vancouver or Ribbon Community. It actually was initially a program of AIDS Vancouver Ribbon Community, but the thinking at the time is that we were not attracting actually guys to come to HIV prevention activities as it was associated with an AIDS service organization. So let's hone in on that for a second. Stigma is a problem both for prevention and treatment with HIV, right? So it became existent really as a way to showcase a different model of healthcare, kind of starting with the prevention conversation. So HIM was in on conversation around post-exposure prophylaxis alongside the BC-CfE, piloting that program for non-occupational folks, which the BC-CfE was wildly supportive of, and saved a number of people from infection. So we've been working in this paradigm kind of in large kind of ways, connecting gay men in this province, who at that point at the beginning of our work at HIM were the most significantly represented living with HIV. So we existed to fight against it and get people the information into their hands so that they can have the best information possible. So we've been teaching people how to navigate systems, how to get on HIV medications, understanding U equals U, understanding CAS, understanding PrEP when it came out, understanding Doxy when it came out. So a lot of our work happens in information. But we also run the largest STI clinic in the province. The Himo Daily Health Center, not but 200 meters away, is the busiest STI clinic in the entire province. We've just been confirmed this by an ACH audit that went through this to figure out if we were doing this. It turns out we are. Because, so that's where we've been at. So we have 2 large clinics in Vancouver, and then there's an array of clinics across the province where we partner with regional health authorities to provide an array of prevention services up to and including connection to HIV treatment, whether that is for prevention or treatment of HIV. Where we're at now is that a similar point to when HIM started. HIM started when, at a time where HIV rates had decreased. It was around the 2004-05 point, and then they started to go up again. HIM came along to kind of connect with the people who had not yet gotten HIV, which we did. But now, we're in the situation again where the numbers are going up and they can't stop it. We can't stop it because it's new, it changes, it's an ever-evolving paradigm. And the way that we've been involved is consistently connecting with the community, having conversations and figuring out where we can be. So we will get epi data, for example, on groups of people that are most at risk of infection or getting in contact with HIV. And then we develop initiatives to match and lead those populations. In the last year, we've hosted 4 Spanish-speaking testing events that bring together the Spanish-speaking community, Latinos, Latinas, Latinx people, to come together and get tested, learn about HIV, and bring that information back out into the community. And we think we're testing around 40 people per visit. A lot of those people are PrEP naive, treatment naive, test naive, naive to all services, which just shows us that actually globalization is a major issue here, which is why we can't just focus on BC. What we're seeing at HIM is that intravenous drug use is increasing as a cause of HIV, as well as in certain populations of Latino newcomers. So we realize that we have to pivot our services to adapt and meet the people who need those support most. And this is what we've always done. We've always released campaigns to align with current trends. If syphilis is on the rise, we'll release a campaign about that. We're entering a new challenging paradigm where it isn't just gay men that are impacted anymore, because we've always known at HIM, despite having a pronoun for our name, we've always known that HIV is not a men's problem. It is not a women's problem. It is a global human situation that we all have to think about in our various jurisdictions to deal with. So that's kind of where we've been at. I would probably talk too much. I'm going to hand it over.
Thanks, Aaron. So yeah, just a few words about HIM and the work we do. So as I mentioned, we're a provincial network of 40 community-based organizations throughout BC. And our members are responding and very active in responding to HIV, but also viral hepatitis. A lot of our members are also working to respond to the ongoing drug poisoning crisis. So I will just say, as a contextual piece, that has the toxic drug overdose situation has had a huge impact at the community level and on PAN members. And I think that it's put a huge strain on resources and taken a huge toll as well. And so I think a lot of PAN members are feeling very stretched thin and trying to continue their really important work with HIV and testing and prevention and linkage to care, and then also dealing with this like massive crisis that's basically on their doorstep and in their hallways pretty much every single day. So what PAN does, we try to support our member organizations in a number of different ways, and just a few things about PAN that you may not know. For over a decade now, we've been running a leadership training for people living with HIV called the Positive Leadership Development Institute. And that was developed by and for people living with HIV. So over 300 people now in BC have taken this training, which they are asked the question, who am I as a leader? And folks are supported in determining their own leadership style. And then we also have trainings in board governance if people are interested in volunteering on a board of directors. We have training in communications, and now recently we've just brought on a facilitation training as well. So, and as a result of that, I think PLDI has built an amazing community of leaders, and people are going forth and either amplifying the work they were already doing in community, or they're finding new roles as peer researchers, as board members, working in the sector, but also in healthcare and in academia and in research. And so in terms of research, what our approach is, we try to lead and support research that really matters to communities. And again, we do this by bringing together people living with HIV and community-based organizations and connecting them to academics and researchers and making those linkages. And so PAN and our members and many of the peer research sit at many different research tables, including here at the BC Centre for Excellence, and the different projects that have happened currently or historically, engage, shape, pursue, retain, et cetera. And often we have researchers from BC-CfE sit at our tables and support our work as well. And right now, one of our largest research projects is actually working with people who use drugs and also people with history of incarceration who are living in smaller, rural, and remote communities, and working on their research and policy change priorities regarding STBBI linkage, testing and linkage to care. We're presently working in partnership with the BC CDC to develop a provincial STBBI testing guidance. So we're conducting, again, consultation across the province with healthcare providers, community-based organizations, and people with lived experience to come up with an STBBI framework. And then one last thing I'll mention is a lot of our work is also around providing in-person and virtual capacity building opportunities with our members. And so the way we approach that is we ask our members, hey, what do you need on the ground? The folks on the front lines, like, what are you struggling with? So we work with our members and also people living with HIV and other peers to develop programs and services that are going to be meaningful and relevant to them. So some things that we've worked on recently in the past are things around cultural safety and reconciliation, testing and linkage to care, HIV and aging, how to interpret epidata, how to evaluate your programs and services. So yeah, it can really look different, and we really try to be responsive to what our members are dealing with, because again, often the situation can look really different as well outside of the Lower Mainland, and we know that like for folks who are living in more remote or rural or even smaller urban communities, the access to care and to testing and to supports, and even just having a family doctor, it can look much different and way more challenging. So a lot of what PAN does is try to really do as much as we can to support, again, organizations and communities who are perhaps less well-resourced and bring their voices forward. Yeah, so I think I will leave it at that for now.
Thanks so much. I want to open it up to the audience now. Hoping people have got some questions. If you have, put your hand up, I'll kind of signal to you, and then if you can press the little white thing in front of you, then everyone can hear. Thank you.
Hi, thank you so much for everything everyone said. In the perspective of funding being cut, I just want to bring up another icon of BC that everyone forgets is from BC, with Naomi Klein, whose book Shock Doctrine describes a current moment where political attacks and cuts to things that should be basic, just accumulate and mount, and then it becomes too much for anyone to address at once. And so within this, it seems to me like HIV prevention is being attacked among so many other things that it stops being a priority and it falls off the radar. So in this context of shock doctrine, what haven't we tried? What can we do in a time when the funding is not going to expand? We're in fact going to see a shrink. What can we try to do differently to empower communities to have agency over their testing and prevention, to protect themselves, and to continue progressing this work in a grassroots space, since the top-down is no longer on the side?
Thank you. That's a great question. My answer, and then I'll hand it over to my esteemed colleagues, is I think that what we haven't tried yet before is ultra-intentional connection between institutions like BC-CfE and institutions like PAN and HIM. What we're hearing from governments is that we're not trying to cut frontline services. We're not trying to cut frontline services. In a way, I believe organizations that are in greater jeopardy of more government cuts should connect themselves to community organizations. Because what they're telling us is they don't want to cut us. If we connect and we show how unified we are, I think we become much more resilient. So that's the strategy I think hasn't happened yet. Of course, we've been working with each other passively, but I think it's time we try to stand actively, to support each other so that we can protect each other.
Yeah, I would just echo that 110%. I think, like I said at the start, I think now more than ever we need to be working together. And, you know, Julio, you're an amazing advocate. And when you look at, for example, the BC Centre for Excellence call to action, you know, getting TASP and PrEP on pharmacare,
finally addressing the criminalization of people living with HIV.
You know, I encourage everyone to take a look at that. Like, there's 7 points there. They're all excellent. And I think that
We need to be working together and singing the same song. And again, that's why I'm just so thrilled to be here today and to be invited and to speak to you all, because I think
we really need to be reinforcing each other's messaging and aligning, and, you know, PAN needs to be supporting Dr. Montaner and his messaging, and Dr. Montaner, you know, should be supporting our messaging as well, and just having this like really strong united front.
I agree with everything that has been said, and I want to add, in addition to the plan that is in our website, which is fairly well detailed, what we need is to harmonize strategies across the country. The policies related to HIV/AIDS in this country are a mess, and they vary by province in ways that are totally detrimental. We have no harm reduction strategies across the country. It's a disaster. We have no agreement in the criminalization of HIV exposure. Everybody knows that HIV exposure is over-criminalized, and yet nobody's doing anything about it. So there are simple things that can be done. We have no consensus about the use of PrEP. I already showed you data that shows PrEP is actually super inexpensive. It's a generic medication that anybody can ultimately take, and yet we're not using it. Why? Because of prejudice. So there should be a federal guidance that occupies all of these domains. And with that, we can move the issue forward. If I was in charge of UNH today, which I'm not, I would argue that the number one thing that UNH could do at a very, very low cost is to increase the coverage with PrEP by tenfold. It'll cost nothing, and it will have a dramatic impact on the continued expansion of the epidemic. The problem is we're not thinking clearly, and what we're doing, I agree with you, is basically like we're allowing the shot doctrine to prevail and looking at it and saying, we're impotent. Why? Because we're being bombarded by the idiot down south with all kinds of crises, and so we cannot respond. We need to get real, and we need to demand from our policymakers that they pay attention, because at the end of the day, if we don't do this right, we're going to be inundated with HIV, syphilis, gonorrhea, chlamydia, hepatitis C, all of which are preventable.
If I can just jump in, I agree with all of those. I also think, and when I see the politicians and talk to them here in BC, I recognise that it's actually pretty tough to be in the world right now. Like, you just think you've got a plan, and then you wake up and, I don't know, Trump's done something new, or Ontario guys put out an ad and suddenly there's a whole load more tariffs on softwood, and, you know, it's actually kind of tricky. And of course they are absolutely being bombarded with people like wanting more, basically, in terms of, look, don't cut our funding, we need more for this, we need more for that. And all of those are good and absolutely reasonable responses. And we need to keep being one of those voices. I also think we need to make sure that people and governments get kudos for when they make the right decision. I think about PrEP. And the decision which, thanks to Dr. Montaner and the team lobbying Adrian Dix did, I have a good friend who is a PrEP customer, and he always says to me, this is amazing. My friends in San Francisco don't get this. They can't afford this. And so I think at the same time as absolutely lobbying to do better, we should definitely acknowledge our good fortune to be living in BC and where our government has made the right decisions, and to keep reinforcing that was actually an amazing decision and has saved many, many lives and many people from infection.
Yes, I just kind of had a question for any of you. When it comes to HIV, I find it's a very hidden illness, and that's why governments can just ignore it. I mean, recently, sorry to say it, because I have had cancer myself, how many times are we going to see baseball players or anybody holding up saying, I know somebody with cancer? It's really difficult for me to watch that and know that HIV is never recognized. And so my question is about stigma. And to me, there's 3 types of stigma. There's the stigma you have of yourself. You're embarrassed, you don't want to tell people you've got it because you think you're a bad person. There's the stigma you have, your perceived stigma, what somebody is going to say about you if you reveal it. So that's perceived stigma. And then there's the 3rd type of stigma, which is real stigma, where people are going to ignore you, try not to touch you, walk away from you. I'm just wondering, what kind of stigma do you think we're facing right now? I mean, I know we're facing all 3, but what is the stigma that's happening more than any other type of stigma?
As a young gay man who was bullied, you get to experience that when there's a bully at play, they'll use all of it. It's all of it. And I think that in Canada globally we're faced with the situation where I make the joke at him, I say, it's like we just jumped off the Blue Nose. We just fell off the Mayflower. We're in a time where we are so puritanical that the minute anything has anything to do with sex or drugs, it becomes really easy to sweep under the carpet, and you can amplify other things. I do think that that systems abuse all forms of stigma, and people use those same stigma to back their own vantage points. The fact that there's a medication that prevents HIV, but there are doctors who think it's a better idea if people just don't have sex, that's a problem. And yet, countless policymakers and doctors agree with that phenomenon, but they don't talk about it because it's reinforced. So that's, again, I'm going to go back to, that's why we need the conversation happening at all levels. You need angry trans people wearing neon clothes yelling outside. You need parades and prides, and you need research institutions providing good data. We need all of it, and we need to start amplifying it, absolutely. I think it's all 3 levels of stigma, even the personal, because they're relying on people being ashamed and not saying anything, which is why we also have to uplift people living with HIV first so that they can speak. Indigenous people first so that they can speak. It really is invincible. I'll tell you, that type of resistance, it is invincible. Institutions have come and gone. Academic institutions, community organizations have come and gone. the phenomenon of that resistance that comes, that we can all practice at all levels. Julio does it every day. Evin does it every day. I do it every day. We have Michael from community here. He does it every day. We have staff at the BC-CfE who do it every day. That's my thought.
Yeah, I agree. I think all three levels are continuing. One thing I do find encouraging, though, is the way, like, the leadership of people living with HIV. I feel like there's been such a powerful groundswell that I've been privileged to see, and I feel like more and more people are taking up space and taking up the voice that they need and demanding to be heard, and that I do feel like there is a bit of a shift within healthcare systems, at least, to basically say, yes, we're gonna listen. We're gonna listen to those voices of people living with HIV. We're gonna listen to the voices of people who use drugs. We're gonna listen to Indigenous communities and people, and sort of like really start. I am encouraged. There's more reflection about, okay, how are our healthcare services and the other supports that we're providing, how are they stigmatizing people still, and what improvements can we see? So that, on the one hand, is a very positive and encouraging thing. I think on the other side, that is what is super discouraging is I feel like the polarization of society in general, and sort of like that really othering of people who are different, and be they people living with HIV or people who are most at risk, people who are poor, people who are houseless, people who use drugs, like they are being demonized and vilified and made into political, I don't know if the right word is, punching bags. And so that's the other kind of force and challenge that we're up against. So it's kind of a mixed thing, but I do really feel that the voices of people are getting stronger, and so that's encouraging.
I don't have much to add to that. I simply wanted to share with you the fact that, in my opinion, HIV/AIDS has lost the preeminence that it had in the 80s and 90s. And I don't know how we're going to fix this. I try every day. We all try every day, but it's not working. To hear that Canada, for the first time, has cut the funding to the global health is painful. At 5 years away from 2030, the end of the strategy. To hear that the UNH is being phased out, it makes me cry. This is pathetic. We need to get angry, and we need to show it. The passivity that we have demonstrated over the last decade, the complacency that we have shown, is actually negligent. We need to get loud and clear. I've been trying to get the message through the press, and they don't even care. I spent the morning yesterday with the CBC, the National, and what they did in yesterday night's news was pathetic. There is a crisis going on, and they don't even get the message. And I gave them all of the data, and they're not interested. Nobody wants to take on Mr. Trump. Why? We had to. Somebody has to do it. He should be against the International Criminal Court for crimes against humanity for the withdrawing of the fund for PEPFAR. That alone, let alone everything else that he's doing. And nobody's paying attention. I'm very concerned that we are going to lose the battle. And I don't have time for that. We need to finish the job, that's all.
Yeah, thanks everybody for your wonderful presentation. I'm a person living with HIV for 37 years. I've gone through all these stages of how I feel about that. I think one of the biggest, most armoring thing that I learned was you equals you. That was the time when I stopped self-stigmatizing. I felt it was just about that power, that sense that I was okay with myself. And I've been doing some research lately. I worked with BC-CfE. I'm going around the province, and I am aghast with the number of healthcare workers, people living with HIV, who have never heard of that. And for someone to want to engage with care and make the decision to take medication, to get treatment, if they understand what I've heard, or their people around them and their family know what that means, I feel that would be a bigger change or shift towards people engaging in health care, reaching those targets. But I feel it's a forgotten sort of thing. I know with him that's all about information. You're mentioning that stigma is also an issue, getting people to connect to care. I think that is a big underlying theme that really needs to be enforced globally, provincially, nationally, and if you could just be within our consciousness. And it's not fake news, it's real news. It's, and that has, we're getting people coming from all different countries, with different programs, different awarenesses, and a lot of stigma. So I just would love to see more of that just really out there.
Yes, absolutely. Does anyone just want to agree?
Yes.
Total wholehearted yes. Yeah, U equals U is so important, and I do feel, I'm not sure why, but I feel like the awareness, like there was a lot of momentum and trying to get folks, and then it sort of just has, and I don't know why that is. So thank you. That's a good reminder for me for the work I do, like to be thinking more about U equals U and getting that message out there. So thanks.
I think we have time for one more quick question. Yes, sir.
Hi, so I just wanted to ask if we can share anything in terms of what's going on with the young people, because I've been hearing, that, well, they don't get engaged in community settings as much, they're not having as much sex in some surveys apparently, or it's just like changes, generational changes, and I don't know if they're engaging with PrEP and other services, with treatment.
They're absolutely. I'll talk about youth for a moment here, but there actually is a generational factor that we have to think about here. Is that depending on when you grew up and when you were alive, there was a lot more activism. Julio is not wrong. We actually do need to get loud, and the we of who needs to get loud is the community. The community has that ability to get loud. We have the ears of governments in different ways. I have long been thinking that it's time we unify on the campaign. The last 6 to 12 months, and is quite loud on this, but the young folks, so we have a number of programs at HIM, because at HIM it's not just about getting people on PrEP and giving them condoms, it's everything. We have them in mental health groups, we have them in counseling supports. We have, so our counseling program is disproportionately favoring young folks. Our testing services tends to favor the same age as is most sexually active in most groups, which is 25 to 39. We also have numbers of groups that are coming in and wanting to lead, young people wanting to lead different initiatives. We actually recently had to develop a new sexual health resource that was designed for the younger generation, because they don't think about HIV in the same way. They don't think about it as a men's thing. They don't think about it as a big deal. So actually, even within the youth, we have a responsibility to educate them about how things work, which is why we, organizations like HIM and Vancouver Men's Course, are trying to do intergenerational dialogues to try and keep that that generational context going. But what I absolutely have heard, younger people are having sex differently. They're going out differently. The paradigm of what we used to know in community has changed. We can't let that offset our footing. I think that's what I always tell my team is that, yes, there's the younger generation is having sex and practicing in a different way, absolutely, but that doesn't mean that there isn't a huge population that still is functioning in this particular way. So I do think early intervention is really important. I've been working with the Foundry on a number of their projects to make sure HIV and Hep C and sexual health stays really high on the agenda at the Foundries. And I really do think more education about HIV specifically and the prevention initiatives that BC have done need to get into the curriculums in schools. People need to be taught about what happened. And I think that would make a difference in early intervention, but it's a tricky paradigm because of the ways that organizations like ARC and SOGI 123 and HIM have faced with getting boundaries and getting into schools, which is where you need to get to them. You need to get to them grade 11 or 12, or else they're lost. They're in the wind. and they're very difficult to find. But it is a very challenging paradigm, and we've got a few consultation groups, and I always encourage everyone, keep asking young people questions. Keep bringing them in and asking them questions. They're super insightful. They will help you figure out, if you're having a problem reaching young people will help you figure that out. It's really easy. Pay them $50 and get pizza, they'll come in and they will tell you.
I'm really sorry, we're running out of time. If you just had, if there's anything you're good? Thank you so much. I feel like I had one job this morning, which was to respect people's time. And so thank you for the fantastic questions, really interesting. Thank you for your attention. Thank you so much for our fantastic panel. The words that I am leaving this room with, and I hope may be of use to you, are words from a poem which I really like from Robert Frost, which is all about a moment of reflection, of thinking, and then kind of recommitting. That's how I interpret it anyway. And the poem goes, the woods are lovely, dark and deep, but I have promises to keep, and miles to go before I sleep, and miles to go before I sleep. I think what we have all heard this morning is we all have miles to go before we sleep. Thank you so much.